راح نبلش المحاضرة. مساء الخير أولا. المحاضرة اليوم هي عن cardiomyopathies. definition of cardiomyopathy. It's a heterogeneous group of diseases of the myocardium associated with mechanical or electrical that usually exhibits inappropriate hypertrophy or dilatation, and due to a variety of causes, frequently genetic. They are either confined to the heart or part of a general systemic disease. So, in summary, it's disease of the myocyte. وهذا بيكون associated مع mechanical problem with the ejection fraction أو electrical dysfunction. هلا الكلاسيفيكيشن في عندنا ال MOGES اللي هي موجس classification. والموجس classification M refers to phenotype, whether it's dilated or hypertrophy. والO refers to organ with or without extracardiac involvement. G refers to genetic transmission, هل هي dominant or recessive. وE refers to etiology, genetic disease with disease gene and a mutation if known. Well, S refers to disease stage. So MOGAS classification, the WHO classifies myopathies based on anatomy and physiology into 5 subgroups. Dilated cardiomyopathy, where the ventricle is enlarged with systolic dysfunction. Hypertrophic cardiomyopathy, thickened diastolic dysfunction is the title. Restrictive cardiomyopathy, diastolic dysfunction is the main finding. Arrhythmogenic right ventricular dysplasia, or ARVD, where there is fibrofatty replacement of the right ventricle. And the unclassified مثل الفايبروإلاستوسيس والleft ventricular non-compaction. For dilated cardiomyopathy, here the left ventricle or both ventricles are dilated, and this is not explained by abnormal loading conditions or coronary heart disease. يعني زي ما تحكي idiopathic أو genetic. هذا الأوريجينال definition of dilated myopathy. راح تشوفوا ببعض السلايدات إنه عم نذكر etiology. هذولا يعني راح نعرج عليهم لأنه they resemble dilated cardiomyopathy بس with known etiologies. فممكن نحكي عن ال coronary heart disease، ممكن نحكي عن myocarditis إلى آخره. ولكن أصل الديفينيشن للdilated cardiomyopathy is the one that's idiopathic, where there is genetic component of it. Again, it's characterized by enlargement, and the wall thickness is nearly normal, and there is excessive fibrosis present. Patients usually develop heart failure, arrhythmias, and increased risk of sudden death. Due to the dilatation of the left ventricle and right ventricle, the annuli are dilated. That leads to regurgitation. As we have talked about this, the etiologies of dilated cardiomyopathy are varied. Ischemic compromises the most, then valvular, hypertensive, familial. Idiopathic is where the original definition for dilated cardiomyopathy. Inflammatory, including infectious and non-infectious. Toxic, like alcohol or drugs like anthracyclines. Metabolic, nutritional, and neuromuscular disorders. Now the dilatation, بس لحظة شوي نتأكد. Okay. The dilatation and impairment بالmyopathy leads حكينا to reduce systolic function due to myocyte damage. There are multiple etiologies. الإيديوباثيك اللي we are alluding to هي rare يعني 5 بال100,000 والincidence is likely higher due to the mild asymptomatic cases. It's 3 times more common in males and African Americans. The inherited dilated myopathy, it's 30% of the cases of idiopathic. Inheritance varies, ممكن تكون dominant, recessive, or X-linked, or even mitochondrial. Associate phenotypes occasionally present. The mechanism is energy production, mitochondrial, contractile force generation. These are the issues. When they look at genes, the gene titin, which is the giant protein that controls the stiffness of the sarcomere, is the main one. And it's responsible for nearly 20% of the familial dilated myopathies. إذن لما نطلع على idiopathic هي 5 to 8 per 100,000. 30% من هذول idiopathic are familial, where there is a genetic format. فإذا تتذكروا بالدefinition بالبداية حكينا dilated myopathy هي regardless of coronary artery disease or loading conditions. يعني loading conditions يعني mitral regurg, aortic regurg. But in the absence of these, dilated cardiomyopathy as a genetic disease highlights itself. Now, when we talk about the other etiologies, there is a specific cause to be treated, to be diagnosed إلى آخره. فهذولا بيكونوا نفس dilated myopathy in morphology, بس the original definition goes back to the idiopathic ones. فمن المسببات هي الميوكارديتس. Myocarditis, whether it's due to infectious or non-infectious, microbial viruses particularly. والnon-infectious حكينا مثل الكحول والanthracyclines. There are 3 different phases. At the end, there is a direct myocyte injury, and occasionally there is an immune response due to the antigen, like an autoreactive myocarditis. So dilated cardiomyopathy can be caused by myocarditis. When we look at viral, the most common is Coxsackie B virus and echoviruses and occasionally adenoviruses, which are responsible for the common cold. Usually they are self-limiting infection in young people. There is myocyte cell death and immune-mediated injury, but they have no response to immunosuppressive therapies. So usually supportive care with, with just NSAIDs or antipyretic therapy. So ما في role other immune mediator therapy despite a possible etiology of immune mediated disease. So مش دائما بالميديسن بالضرورة إنه حتى لو بتعرف الاتيولوجي يكون العلاج effective. وهذه من الكيس سيناريوز إنه أنا في عندي immune mediated injury, why steroids and others are not the patient is not responsive. Again, this is based على evidence-based medicine, not only theory. Non-infectious, there is an inflammatory reaction. وحكينا هذولا من الأمثلة عليهم drugs مثل الانثراسايكلينز وال other toxins like alcohol. أحيانا بيكون جزء من systematic disease like Kawasaki. When you do cardiac MR, CMR, it's a powerful tool in the recognition and assessment, and the gold standard is biopsy if you are not certain about the etiology of the disease. Now, alcoholic cardiomyopathy, chronic use, 80 grams a day for 5 years. So this is for heavy drinkers. If they use this amount of alcohol for 5 years, it's reversible with abstinence. It still compromises nearly 1/3 of the cases of non-ischemic cardiomyopathy. There is myocyte cell death and fibrosis. It affects the energy producing and the oxidation in the myocytes. Now, the dilated cardiomyopathy due to peripartum disease usually happens in a pregnant woman in the last trimester, especially the last month of pregnancy, and postpartum, the 6 months after delivery. There is LV dysfunction. It's 1 in 4,000 women. The risk factors that, the females who are at risk are the ones who are multiparous, yani who has children at home, not primary. African American females, those with history of hypertension, preeclampsia, and alcohol users and tobacco users. The mechanism proposed is related to a pituitary releasing prolactin. This induces endothelial microRNA 146A and the placental release of the SFLT, which is a tyrosine kinase receptor. Both of these substances, the SFLT and the microRNA, cause apoptosis and cell death in the myocytes. So a placental antigen and the microRNA from the endothelium. This is a autopsy showing a dilated cardiomyopathy case. This is another autopsy showing a patient who suffered an anterior myocardial infarction, where you can see the white endocardium all the way transmural is due to a scar tissue following the MI. So the ventricle is dilated. This graph shows you the prognosis of patients with myopathy depending on the underlying etiology. But you can notice that the worst prognosis is HIV myopathy. The one next to it is infiltrative. Then chemotherapy carries also poor prognosis. Ischemic heart disease is better. Idiopathic myopathy is better. And the best here is peripartum cardiomyopathy has very good prognosis to recover. Moving on to hypertrophic cardiomyopathy. So the first disease is dilated cardiomyopathy. The second is hypertrophic. Here, the ventricle has normal systolic function and even supernormal, while the ventricle is quite thick, despite there is no afterload increase. يعني ما عندهم hypertension, ما عندهم aortic stenosis. It's just a genetic variety where the ventricle is thick and hypertrophied. Now, the ASH or asymmetric septal hypertrophy is the most common variant, where the septum is very thick. The other walls are within normal. There is another variant, the symmetrical, and the third one is the Japanese Yamaguchi, اللي هو Japanese variant اللي هي apical hypertrophy, where the apex is hypertrophy. Usually has better prognosis than the asymmetric septal hypertrophy. حكينا there is vigorous function, systolic function, but there is the title of it is diastolic dysfunction. لأنه دائما لما نشوف إحنا hypertrophy و increased thickness بنفكر بالdiastology. So diastolic dysfunction is the main issue here. Prevalence, this is common, and it's considered the most common cause of sudden cardiac death in those less than the age of 35. It's as common as 1 in 500 in the general population. The etiology, it's familial in around 50% of the cases with autosomal dominant transmission. One of the 4 mutations are seen with differences. فبنلاحظ الموست common البيتا MHC اللي هو بيتا مايوسين هيفي تشين. تلاحظوهم على الكرتون موجودين، مثلا بشكل هذا 35%. Cardiac troponin T هذا again بشكل 15%. Myosin binding protein, that's 15%. And alpha-tropomyosin. Okay, so these are the most common genetic or genes that are involved in the etiology. This is an autopsy of a deceased patient who has hypertrophic. تلاحظ هنا كيف الوول اللي بين الليفت والرايت ventricle is very thick compared to the others. فهذا asymmetric septal hypertrophy. You can see the same here. This is another patient with mainly هنا concentric hypertrophy. شو بيصير معهم هدول المرضى؟ نتيجة للhypertrophy كون they are at risk of ventricular arrhythmias, so sudden death and syncope. Left ventricular hypertrophy حكينا is associated with high end diastolic pressure, يعني diastolic heart failure. فالمريض بيصير معه dyspnea. Due to the increased thickness, the requirements are more, so oxygen consumption is increased, so that leads to angina. عدا عن ذلك, when we go to dynamic LV outflow obstruction, which happens in a large proportion of the patients, the dynamic obstruction where we hear a systolic murmur, which is increased by Valsalva and increased by standing, anything that lowers the preload, then in that patient group, those with obstruction, there is a increase in systolic pressure that is inside the ventricle, which is not transmitted to the body لأنه في obstruction. There is mitral regurg لأنه mitral valve plays a key role in the obstruction. The anterior mitral valve leaflet moves in the direction of the septum and gets to be sucked in to a vacuum and the left ventricular outflow tract. يعني الاشي اللي بنسميه SAM اللي هو systolic anterior motion. So في عندي ASH asymmetric septal hypertrophy و SAM systolic anterior motion of the mitral valve, which leads due to this effect, Venturi effect, بيؤدي ل mitral regurgitation, failure to increase cardiac output with exertion, again due to the obstruction, which is a dynamic obstruction, unlike aortic stenosis. Dynamic, why? Because it changes with position, it changes with basically the preload. What determines the preload determines the symptoms. For example, the patient is dehydrated, then he's more symptomatic. If the patient is standing, then he's more symptomatic. If the patient is taking diuretics, for example, for whatever reason, then he is preload depleted. So anything that leads to more obstruction leads to more symptoms. Hello? بعد إذنك بس لحظة دكتورة. مساء الخير، معي الدكتورة هبة يا طلابنا. أنتوا طلاب سنة رابعة مزبوط internal medicine؟ لأنه في بعض الطلاب بيحكوا إنه ما في محاضرة، بس أكدوا لنا لو سمحتوا حدا منكم. هذا عم يبعث لنا thumbs up. أنا بدي حدا يحكي. بدي حدا يحكي لي إحنا طلاب رابعة.
إحنا طلاب سنة رابعة.
شو اسمك أنتي؟
أنا جود مصلح.
جود، هاي جود من رابعة بتقول لك إحنا طلاب رابعة. ماشي. والله عادي ما بعرف. ماشي أوكي هلا. والله ما بعرف. كيف أنتوا دخلتوا يا طلابنا؟ دخلتوا على ميديسن 1 جود
على
بتحكي
تيمز
لي دخلوا على ميديسن
ميديسن.
1. اهلين دكتوره، اهلين.
يمكن في أكتر من تيمز،
لانه في مجموعه ثانيه يبدو متغلبين بالفوتة، فانا ما عرفت شو اللي صاير بالضبط، بس يعني عم يتواصلوا مع الدكتوره هبه، فما فهمنا شو القصه. على جميع الاحوال hypertrophic cardiomyopathy with obstruction حكينا بيكون في عندي dynamic obstruction، وهذا بيعتمد على البريلود. it's a preload dependent. حكينا عن systolic anterior motion زي ما انتم شايفين بالكرتون. الميترال فالف اللي عنده السهم gets to be pulled into the septum due to a Venturi effect عند left ventricular outflow tract اللي هو قريب على الأيورتا. هذا بيؤدي لميترال regurgitation. فإذا mitral regurgitation is commonly seen in patients with hypertrophic cardiomyopathy. اوكي. عرفنا انه البيشنتس هذول dyspneic لانه هذول المرضى اولا عندهم diastolic dysfunction وبالتالي they have diastolic heart failure. They are dyspneic لانه عندهم mitral regurgitation. They have angina because the oxygen consumption needed is high compared to that provided, وسبب انه high لانه left ventricular mass is very high. Those patients also can present with syncope, which can be due to the obstruction or can be due to arrhythmias. So مهم كثير نتذكر هذول 3 presentation, that angina, heart failure, and syncope, and how do we explain them. All right. Now, when we go on physical examination, patients have a Bispherians pulse, S4 gallop, crescendo, decrescendo murmur, and they have basically the findings that we have talked about in hypertrophic cardiomyopathy. The Valsalva maneuver, which decreases the preload, leads to increase in the murmur. Basically, standing, which decreases preload, also increases the murmur of hypertrophic cardiomyopathy. So it all depends on your preload. Again, أحيانا بدنا نميز بين الهايبرتروفيك كارديوميوباثي والميترال فالف prolapse. بنحكي عن الهاند جريب وعلاقتها بالافتر لود، where hand grip can decrease يقلل الهايبرتروفيك murmur بينما بالميترال فالف prolapse بيزيد. Now we do the ECG and we can see that there are huge septal Q waves in V1 to V3, and there is severe left ventricular hypertrophy by ECG criteria. When we look at echocardiography, we look at the thickness, particularly the septal thickness, compared to the posterior wall, where we can find 1.4 ratio between the septum and the posterior wall. Cardiac catheterization, there are certain findings that you can see in cardiac cath beyond the scope of this lecture. I'll show you some slides on it. Well, this is a slide that shows basically that broken bra sign, broken bra Brownwood sign, which is basically an increase in the contractility following a PVC. And that leads to obstruction. فبتلاحظ انت 2 curves، واحد جوا الليفت فنتريكل حاطين كاثيتر وواحد جوا الايورتا. هلا البلد ما عم يوصل من الفنتريكل للاورتا لانه في obstruction عالي، وهذا الاوبستراكشن العالي كثير وين عم نشوفه؟ خاصه بعد البي في سي. فبعد البي في سي بصير عندي سيفير، يعني بصير في بوز، وبعد البوز بصير في very severe contraction. هذا الكونتراكشن بيؤدي ل obstruction، فالليفت ventricular pressure بيكون كثير high بينما الايورتيك pressure بيكون كثير low. اوكي، بعرفش اذا واضح. I'll try to show you هنا الكيرسر هذا او هاي laser pointer. Okay, so this is basically the left ventricle, this is the aorta. فلما يكون في عندي PVC followed by a contraction, هذه البي في سي كان في بوز طويل، فالفنتريكل عبى وبعدين اجت فورسفul كونتراكشن. بعد الفورسفul كونتراكشن صار عندي اوبستراكشن اكثر من الطبيعي، ادى لانه الليفت فنتريكولار بريشر يعلى كثير، بينما الايورتيك بريشر صار واطي كثير لان الاوبستراكشن علي. اوكي، هاي اذر بروفوكاتيف مانوفرز مثل الفالسالفا مثلا. هنا اوفرلابينج ليفت فنتريكل مع اورتا في شويه ديفرنس، بس لما عملنا الفالسالفا لاحظنا انه الديفرنس علي. ليش؟ لان الاوبستراكشن علي. فهذا اللي عم نحكيه، انه standing for example valsalva maneuver lead to increase in the obstruction، وبالتالي الجريدينت بين الليفت ventricle والاورتا is increased. I hope this is clear. Now, the treatment for hypertrophic cardiomyopathy, we always like to start with the drugs. The drugs, the preferred drugs are beta blockers, أحيانا calcium channel blockers, وأحيانا the combination with caution though. Now, if you are refractory in regards to symptoms and you have an obstruction, then your options are either myomectomy or alcohol septal ablation. We'll come to that. And this is for symptom relief. As regards to the risk of sudden death, the risk of sudden death is not necessarily مرتبطة بالsymptoms. بمعنى إنه ممكن تكون first presentation. So when do I act to insert an intracardiac defibrillator? We'll show you. So the treatment for symptoms, حكينا medications, particularly beta blockers, calcium channel blockers. If no response, then we move on to alcohol septal ablation or myomectomy. Myomectomy has better long-term results لأنها older procedure, and you can treat the mitral valve issue if it is present at the same setting. The alcohol septal ablation is for surgically non-operable patients. You inject alcohol with a balloon inflated حتى ما يرجع الألكحول على ال-LAD into the septal artery, by so creating an acute myocardial infarction. And this myocardial infarction, with time, that part of the septum becomes fibrosed. فبتبطل hypertrophy، بتكون يعني ضمرت، يعني صغر حجمها لأنه صارت scar tissue. فبطلت in the way، بطل في عندي obstruction للفلو. This is what alcohol septal ablation means. When we look at the correlation with sudden death, بنلاحظ إنه septal thickness أو wall thickness generally is associated with increased sudden death. وخاصة إذا وصل thickness أكثر من 3 سنتي 30 مليمتر. هذا واحد من indication to insert an ICD in patients with hypertrophic cardiomyopathy is the increased thickness. The others are واحد صار معه sudden cardiac death وعنده hypertrophic، واحد عنده non-sustained ventricular tachycardia, family history of sudden death in a young family member, septal thickness more than 30, unexplained syncope. So these are the indications to insert a device. إذن طريقة تفكيرنا بالhypertrophic cardiomyopathy هي إنه أنا بطلع على الsymptoms، حكينا كيف بنعالجهم، وبطلع على risk of sudden death. If the patient has risk factors for sudden death, then he should go for the ICD regardless of symptoms. طب كيف أنا بدي أميز الهارت الطبيعي خاصة بالأثليتكس اللي بيكون الهارت عندهم thick compared to a patient with hypertrophic cardiomyopathy? First, you have to have symmetrical increased thickness بس أقل من 14 مليمتر. هاي الوول thickness، مش الريشيو ال 1.4، ما له علاقة هذا. وأنا بنحكي عن pure thickness. هلا النورمال thickness هي less than 1.1 يعني 11 مليمتر. هلا إذا بشوفه thick مرات بالأثليتس بدي أعرف وين النورمال cut off هي 14. بيكون الليفت atrial size أقل من 4 سنتي لأنه ما في diastolic dysfunction هون. كل ما كان في diastolic dysfunction كل ما كبر الليفت atrium. There is no obstruction to flow. And this is reversible if you stop exercise for 3 months or more. And حتى لو في increased thickness ما في obliteration of the cavity. يعني الكافيتي بتضلها maintaining its dimension unlike patients with hypertrophic cardiomyopathy. Moving on to restrictive. Restrictive cardiomyopathy, there is impaired ventricular filling due to a stiff ventricle. So here, again, diastology is the title. بمعنى, okay, the thickness is not huge زي hypertrophic, but the ventricle is stiff and it's not compliant. For reasons that you will see, اللي هي إنه في protein deposit زي الاميلويد, you replace the myocyte that's stretchy with a protein that is stiff. So the ventricle is stiff, it's non-compliant. هذا الحكي بيعني elevation بالpressures مع أي filling للفوليوم. هذا الحكي بيعني إنه أنا عندي diastolic dysfunction. So diastolic dysfunction هي failure to comply with the volume. The ventricle is less compliant, it's stiff, so it would not adapt any volume. So intraventricular pressure rises with small increases in volume زي ما انتم شايفين بهاي الجراف. يعني بالوضع الطبيعي كل ما زاد الفوليوم بيزيد البريشر بس reasonable. هون مع أي فوليوم قاعد بيكون البريشر أضعاف. فincreasing the pressure بيعني إنه الويدج pressure راح يعلى والمريض راح يدخل بهارت failure. This is the etiology list for patients with restrictive cardiomyopathy. وهاي list you can go through it. Non-infiltrative, infiltrative مثل amyloid والsarcoid, storage disorders like hemochromatosis, endomyocardial, and so on. So amyloid is caused by protein misfolding in which extracellular aggregates of the misfolded protein forms fibrils. Immunoglobulin light chain amyloid and transthyretin ATTR amyloid. So في عندنا نوعين اللي هو البرايمري amyloid اللي بنشوفه مثلا بالميلوما cases اللي هو الاميونوجلوبولين light chain amyloid. في عندنا السينايل اللي هو transthyretin ATTR amyloid. Restriction caused by replacement of normal myocardial contractile tissue by infiltrative interstitial deposits. And this is an autopsy of a patient, a deceased patient who had amyloid and this glistening yellowish appearance of amyloid tissue. Now, CMR, which is cardiac MRI, is a sensitive diagnostic tool for amyloid. How? Through LGE, late gadolinium enhancement, has been shown in more than 80% of patients. This is basically an imaging criteria that's present in CMR, where you can identify what we call late gadolinium enhancement. Late gadolinium enhancement is seen in 80% of these patients. So PET scan can be used. Definitive diagnosis of this condition still requires histological verification. Now, how to treat amyloid? Amyloid of light chain includes autologous bone marrow stem cell transplant and the drugs. That includes the dexamethasone, the milfelan, immunomodulator agent, and proteasome inhibitor. Now, particularly, this is used for the ATTR amyloid حقيقة. And there are a couple of drugs that are FDA approved for the ATTR amyloid recently with survival benefit. The AL amyloid, we'll see more slides. Well, actually, no. For amyloid, you have to know from now that ATTR amyloid has therapies that are recent in the last 2 years that have FDA approval and they are associated with improved survival. While the AL amyloid, the primary amyloid, is basically carries with it a poor prognosis لأنه الملفلان والsteroids are not really life-saving drugs. They are just used for symptom relief. The sarcoid patients, sarcoid is an inflammatory condition in which non-caseating granuloma involve multiple organs, particularly lungs اللي بتعرفوه انتو فبنحكي أكثر شيء lungs. هلا if it involves the heart, it leads to restriction plus it leads to arrhythmias, whether brady or tachy. فبتعمل conduction system disease يعني brady وبتعمل ventricular arrhythmias. Current therapies, usually steroids, they are responsive, and other immune suppressive therapies. The endomyocardial fibrosis is endemic in parts of Africa. Actually, بتشكل 25% of cardiac death in equatorial Africa. And this is basically the same as hypereosinophilic syndrome, low Effler's endocarditis. There is thickening of the basal inferior wall, where there will be development of thrombus, seen here as apical obliteration with mitral regurgitation. So you can see on echocardiogram الصورة اللي على اليمين إذا هون بتنتبه, this is the left ventricle. This whole area هاي المفروض تكون فاضية بس هاي full of thrombus. This is what hypereosinophilic or low Effler's endocarditis look like. So this is endemic in parts of Africa. Luckily, in our area, we are saved from this. The pathophysiology of restriction, again, there is decreased filling, there is decreased ventricular filling, and that leads to decrease in the cardiac output. And there is increase in the pressures with minimum volume, and that leads to congestion. So just like any patient with heart failure, increase the pressure in lungs بتؤدي إلى congestion, will increase pressures in the right atrium leads to congestion on the systemic side. By the same token, a drop in the cardiac output leads to fatigue and weakness. So patients with restriction, they present with dyspnea, orthopneas, peripheral edema, ascites, hepatomegaly, mainly right-sided findings are present. وحكينا عن fatigue with decreased exercise tolerance. Clinically, it mimics those with constrictive pericarditis. There are certain echo parameters, again, beyond the scope of this, ولكن basically the short filling time in diastole is represented here, where usually this is a wider filling envelope that you see on Doppler. The shortened time لأنه البريشر بيعلى بسرعة بالventricle, so the mitral valve بيسكر. This is the mitral inflow, basically, of the blood. Now, the prominent Y, dip, and plateau findings are also seen in patients with restrictive cardiomyopathy. Treat the underlying cause. For example, amyloid, حكينا إذا كان primary, milfelan, prednisolone, endomyocardial fibrosis. Hemochromatosis has better prognosis because usually hemochromatosis happen in patients who receive blood, like those with thalassemia. So you give them chelation therapy, مثلا desferoxamine, عشان to avoid iron overload. And you do weekly phlebotomies to avoid iron deposition. So this is one of the storage disease that leads to restrictive. It also leads to dilated cardiomyopathy, by the way. Diuretics and other treatment options for heart failure, pacemaker for conduction systems, زي ما حكينا بجماعة الساركويد, they are prone for conduction problem. Anticoagulation for thrombus and transplantation when possible. Arrhythmogenic right ventricular dysplasia. In that group, there is fibrofatty replacement of the right ventricle. So المصل بيروح بيجي محله fibrofatty tissue. There is a dilatation of the right ventricle and dysfunction. Patients who have this condition are at risk of sudden cardiac death at a young age group. This is mainly Italy, Greece, where in these areas, young patients who suffer sudden death, ARVD is considered the dominant cause. What happens there? There is abnormality in the intercellular adhesion molecule. Intercellular adhesion molecule, or ICAM. The desmosome this causes cell death and fibrofatty replacement. These abnormalities are caused by mutation in genes PKP2 and DSP, encoding plakophilin 2 and desmoplakin, respectively. Inheritance is dominant mainly. هلا على الاي سي جي بتشوف شيء اسمه epsilon wave, which is a delayed repolarization following a QRS, and the diagnosis is through MRI, so CMR. This is the ECG where you can see the epsilon wave following the QRS. Treatment consists of cessation of heavy exercise, like those with hypertrophic cardiomyopathy. Now, you could offer ablation therapy of the arrhythmia, and you can offer also an intracardiac defibrillations. Patients with heart failure may require cardiac transplant, and genetic screening is recommended. This is a CMR. This is the left ventricle. Normally, the right ventricle is very small and has an elliptical shape. This is a spherical shape with dilatation تقريبا السايز تبعه قد left ventricle. There is aneurysmal formation. So this is a classic cardiac MR for ARVD. Finally, left ventricular non-compaction. And left ventricular non-compaction, there is a prominent trabeculations with deep recesses in the left ventricular apex. Usually, patient can present with heart failure, arrhythmias, or thrombosis in that area. You need to screen the offsprings for possible inheritance. So هون بنلاحظ the deep recesses that are present, بمعنى the ventricle did not compact during embryological life. The two layers did not compact properly, so they were separated. مشان هيك بتشوف انت deep recesses اللي موجودة. This is normally not present. Again, the presentation here, heart failure, arrhythmias, or thrombosis in that area. With that, I finish my lecture. بكرة إن شاء الله عنا another one. If you have any questions, please go ahead. Okay. Enjoy the night. الله يعطيكم العافية. نراكم غدا إن شاء الله. Bye.